All right. Hello, and welcome to the second, potentially annual, Teaching Invitational hosted by the Emory Division of Hospital Medicine. I am joined by the Laurel to my Hardy, Dr. Meredith Truitt. How are you this evening?
I'm doing pretty well. I'm hanging in there.
Yeah, we're both on service. We're actually in essentially our office. I mean, slightly upgraded, but we're in our office at the VA doing this live. We're pretty pumped.
Yeah, we're really actually in the resident snack room because if we need snacks during everyone's presentation, we'll be able to have them.
And have a very angry sign telling people not to enter. I'm sure that's going to go well. Okay. Well, enough of that. I'm just so excited to be able to bring everyone together again this year. It was such a great time last year, and just being able to have so many people from across the country on one call is just really cool. So we'll go ahead and keep things moving. So I won't belabor it too much, but I do want to make sure people know how we got here, especially folks that weren't here last year. So Emory has had a teaching competition for almost a decade, I think 8 or 9 years at this point. And it started in person. And then, as with many good things that COVID did, it made it virtual. And we had to kind of rethink how we were going to go about doing it. And we kept doing it just locally at Emory. And then Lenny Feldman from Johns Hopkins was a visiting professor, got wind of the competition. He guest judged a few years ago, and he thought it would be really cool if we could bring together so many institutions. And so over the last couple of years, we've been able to make that happen. It started with some, just good old fashioned awkward Zooms. No, I'm just kidding. We had some people just spectate and see if this was something their institutions really wanted to do. And then we were finally able to make it happen last year. So last year, we had this pretty much the same panel of institutions. We have added one this year, but it was our first one, and Dr. Nilu Latifi won, and she is joining us back as a judge. You'll hear a little bit more about her here in a second. And then, of course, this year, we have the addition of UAB from our original group of Duke, Emory, Johns Hopkins, Vanderbilt, Colorado, and WashU. Really excited to add another great institution to this competition. And so I'd like to start by introducing our judges. First up, we have Dr. Alfred Berger. He joins us from Mount Sinai. He considers himself a New Yorker, and his most meaningful accomplishment, and I'm not going to lie, I embellished a little. He is surviving life with 2 teenagers in his home, as well as being with the most amazing person for the past 20 years. And his fun fact, he once caught a drumstick from Butch Trucks at an Allman Brothers show. I am a little embarrassed, Meredith, to admit that I had to confirm that Butch Trucks was not like an item.
I see how you got there. That took me a second to process, though, how you didn't know that.
Yeah, that one I had to look at for a couple seconds, and I was like, oh, it must be a human from which the drumsticks were caught.
Yeah,
Okay. If we had copyright, Alfred's theme song would be "Free Fallin'" by Tom Petty, but I have a feeling Tom Petty's pretty expensive.
probably.
Yep. All right. Next up, we have Dr. Lauren Heidemann, who's a good friend of this teaching competition. Actually, she was one of our judges at the local Emory Division competition last year. She is coming to us from the University of Michigan. She calls Bloomfield, Michigan, her hometown, and her most proud achievement is in this picture. She was raising 3 wonderful children. She's a triplet, which I forget every time. And then she tells me this is her fun fact. And then I remember. And I mean, why do I keep forgetting? I don't know. Her theme song is really anything by Elton John. And I do know this. I really was curious, Lauren. How do you feel about his recent work with both Dua Lipa and Brandi Carlile?
I have to listen to it more to let it sink in. I'll
Okay.
get back to you though.
Okay. I don't know. I feel like he's in like the living his best life phase, working with like all the cool kids.
Yeah, pretty much.
The coolest of kids, really.
Yeah.
Yeah. It's
But
great.
he just calls them and he's like, I'm Elton.
This is true. This is true. And he's done touring, right? He stopped doing that. That's a bummer. Yeah. Okay. Well, I was just curious your thoughts because you are a true connoisseur of the Elton John catalog. So, okay. And finally, our inaugural winner and final judge is Dr. Nilu Latifi out of Johns Hopkins. She says her most meaningful professional achievement is creating a new clinical scholars program in academic hospital medicine for Johns Hopkins. It's a fellowship. And she's pretty pumped to be recruiting the first class of fellows that'll be joining in 2026. I really really enjoyed your fun fact, Nilu. You and your husband have a monthly tradition of picking a different country's cuisine and you cook it together. Important question. How do you pick which country? Do you like have all of the countries in the world like in a jar and then you just pick it out, or like how do you pick?
Ooh, we will start picking that way from now on. But for now, it's kind of been alliterations a little bit. Right now, May is Moroccan May, so we're
Okay.
making Moroccan food. But we're very quickly getting through that. So I'm gonna pick up the jar idea.
Yeah, I love alliteration, but eventually it does run dry. So
Yeah.
yeah, I was very curious, like what's the methodology to picking. And then I also will say, interesting idea that I got from Meredith once, which is when you are eating these meals that you're cooking from a native country, have you tried adding like authentic music from that country to kind of add to the experience?
No, but you're really adding a lot of spice to my life with all these ideas.
Yeah, I don't know. Meredith suggested it once and I did it and I thought it was lovely. So
Yep.
Is the things we try to do when we entertain ourselves during COVID times. I mean, really. Okay, cool. So I will say that your theme song I found to be offensive and it was a little bit of trash talking, which I probably
So
deserve with all the
successful
trash.
then.
Yeah, her theme song, guys, is "We Are the Champions" by Queen. And this is the payback I get for all the trash I talk every year about Emory and this competition.
Yes, but you will continue talking trash year in and year out.
Yeah, it will not stop. My favorite basketball team of the last 35 years was the Fab Five. So what do you expect? Okay. All right. We will get now to the order of our events. So we have Dr. Michelle Perkins joining us from Duke. She'll be giving her talk on things we do for no reason, precipitating opioid withdrawal with buprenorphine. Then we have Dr. Kevin Liu out of Vanderbilt doing his talk on routine screening for Pheochromocytoma and resistant hypertension. Dr. Kara Grace Leventhal from Johns Hopkins, choking hazard, things we do for no reason, and aspiration pneumonia prevention. Dr. Caroline Coleman out of Emory doing avoiding IV Iodinated Contrast and AKI or CKD. Dr. Aaron Dyer out of WashU for CT or not to CT, neuroimaging for the hospitalized patient with delirium. Dr. Amiran Badushvili from University of Colorado, Denver Health, from Binary to Better, Rethinking the Diagnostic Test Interpretation. And last but certainly not least, Dr. Glenn Carmen out of UAB with Down the Wrong Pipe, Rethinking Anaerobic Coverage and Aspiration Pneumonia. All right, so the rules of engagement are as follows. You have 8 minutes to do your talk, speakers. You will get a 2-minute warning from Monica, so just be aware that it will pop up in your chat as a private message. And then there will be a 2-minute question and answer period. And judges, the conversation in the Q&A is only meant for learning and discussion and should not affect their scores. And for the judges, I do recommend that you complete your scores as each talk happens so you don't get behind. And you do not need to keep time. That'll all be done by Monica and our team. So, and we will stop you if you go over time. So just be aware of that. And it will affect your score if you're not done in time. Okay. And really, it should probably just be the things we do for no reason competition because that theme just seems to be so popular every year. I mean, at SHM, if I recall, we didn't get to go because we were recording, but I think the talk for Tony and Lenny was just standing room only.
Yeah, and I think they had to add a second one even.
Yeah, they give the same. Yeah, so it's just so popular and it's a great thing. So that's our theme for the year. And with that, we are going to get started. Our first participant this year is Dr. Michelle Perkins out of Duke. Her hometown is Wappingers Falls, New York, and she did medical school in Jefferson at Philadelphia, Pennsylvania. She is a 3-year veteran of hospital medicine. And her fun fact, she got legally married on her roof. Is it a slanted roof or a flat roof? I have so many questions.
It was at our house in Philly, so it was a townhome with a flat, like a roof deck. So it's not as adventurous as it sounds like, but it was still really cool. It was during the height of the COVID lockdowns, and so many of our neighbors were spending time on their roofs, and they all cheered when the wedding happened.
That sounds so cool.
It's a very Philly. I can see this in Philly too.
Yes,
that's where
very
you were.
Philly.
Yeah.
Oh, I'm not gonna lie. I was like, were there harnesses involved and like cords and things? I know. I get very dramatic very quickly. And her walkout song, I mean, "Run the World" by Beyonce. Like that should be every woman's walkout song. Let's be real.
Maybe even every man's. Who am I to judge?
All right. We're going to get started with Dr. Michelle Parkins and her talk, Things We Do for No Reason, Precipitating Opioid Withdrawal with Buprenorphine. I'm going to stop sharing. Yeah.
Yes, I can steal it from you, but all right. That sharing okay?
We're good.
Perfect. Well, I will get started. Thank you so much for having me here. Really excited to be a part of this competition. So today I'm going to be talking about precipitated opioid withdrawal from buprenorphine, which I have identified as a thing we do for no reason because it's both harmful and also preventable. So my goals for today are for all of us to learn some basic pharmacology and also dosing principles of buprenorphine to achieve overall increased comfort with managing buprenorphine successfully in a way that does not precipitate opioid withdrawal. So we're going to start with the case. It's 9:30 p.m., you're on an admit shift, and you get paged for an admission. The patient is a 28-year-old woman who presented to the ED for right leg cellulitis. She typically takes buprenorphine, naloxone, or Suboxone every day, but she's not had access to this medication for the last 4 days. About 12 hours ago, she was having some withdrawal symptoms, and so she injected fentanyl. The nurse pages to ask if you'll be ordering her Suboxone as part of your admission. So I'll pause here and give everyone a couple seconds to think about what they might do. So if I think like many of us, you might be about to order it, and then you pause and you think there's something called precipitated withdrawal that can happen when we give patients buprenorphine. So what is that and why does it happen? So I'll have you imagine that this packet is a mu opioid receptor. Now, the receptor could be bound and activated by a full agonist opioid. So these are the opioids that we're all very familiar with for pain control, as well as those that are in the community. So oxycodone, morphine, hydromorphone, fentanyl, heroin, the list goes on. Now, conversely, that receptor could be bound and blocked by a full antagonist, like naloxone or Narcan. Working somewhere in between those two, we have buprenorphine. So there are two properties of buprenorphine that we all really need to understand in order to understand how precipitated withdrawal works. So the first one is, like I said, it works between the full agonist and the antagonist. It has partial mu opioid agonism. It has some activating properties, but not that full effect that our full agonists do. The second thing we really need to understand is that it has very strong receptor affinity. So similar to how naloxone will knock off and replace our other opioids on the mu opioid receptors, buprenorphine will preferentially bind and replace full agonist opioids on those mu opioid receptors. So let's talk about this a little bit more clinically. If we have a patient with active opioid use disorder and their mu opioid receptors are empty, they are likely experiencing opioid withdrawal. If we give them buprenorphine, the receptors are now more activated than they were before, and that patient feels relief of their withdrawal. Now, conversely, if we have a patient whose mu opioid receptors are occupied by full agonist opioids, and we give them buprenorphine, again, that high affinity, it will preferentially bind, and the receptors are now less activated than they were before. This is precipitated withdrawal. I really want to emphasize this, that precipitated withdrawal is from the buprenorphine itself. So it's a very common misconception that it is from the naloxone component of buprenorphine naloxone or Suboxone. And while naloxone certainly can cause opioid withdrawal if we give it to patients, the naloxone in Suboxone is not absorbed when that medication is taken as prescribed. It's only there to prevent misuse by injection. And so the precipitated withdrawal that we're talking about from buprenorphine is from those two key properties of the buprenorphine itself. Okay. So now that we understand a little bit about what this is, let's talk about why it's so important to avoid. So precipitated withdrawal is not only very uncomfortable, as is all opioid withdrawal for our patients, it's also associated with an increased risk of discontinuing buprenorphine, which itself is a life-saving therapy. It has benefits for return to opioid use, overdoses, and all-cause mortality in patients with OUD. It's also precipitated withdrawal associated with an increased risk of self-directed discharge, which again has increased morbidity and mortality. So avoiding precipitated withdrawal is really essential to helping our patients engage with their life-saving care. So now that we have all this knowledge about why we want to avoid precipitated withdrawal and how it happens, let's get back to our case. So for this patient, one thing I want to call out is I mentioned that she used fentanyl 12 hours ago. So we all know fentanyl as a short-acting opioid. And we also are hopefully coming familiar with the fact that fentanyl is really the only component in the street opioids. There's not really such thing as heroin anymore. Fentanyl is so ubiquitous. So it's a short-acting medication, but with long-term use, fentanyl deposits in the adipose tissue and then has a delayed release. And so it can act in our system for 48 to 72 hours or even longer in patients who have frequent ongoing use. And so I've told you that precipitated withdrawal happens when we give buprenorphine to a patient whose receptors are still occupied. And so really what we need to know is, are our patient's receptors still occupied? Or by proxy, is our patient in opioid withdrawal yet? And we can do that by using the COW score. So this is the clinical opioid withdrawal scale. It's available in MD Calc. You don't need to memorize anything. And the most important thing is that this can tell us how severe our patient's opioid withdrawal is. But the number 13 in my little cow logo that I'll use throughout, because this is the really important cutoff for moderate opioid withdrawal. So if our patient has active opioid withdrawal with a COW score of 13 or greater, we know that her mu opioid receptors are empty like this, and it would be safe to give her buprenorphine, either at her prior dose or a high dose induction. We will not precipitate withdrawal and will treat the withdrawal that they're experiencing. Now, if the patient is not in opioid withdrawal, we need some more information to know what her receptors look like. So if our patient has taken buprenorphine in the last 24 hours, it's safe to say it's still in their system. Even if we've gotten full agonists too, it's balanced on the receptors. And so it's safe to continue giving them that buprenorphine. If our patient has not had any buprenorphine in their system for the last 24 hours and has taken full agonist opioids, again, even as long ago as that 48 to 72 hours for fentanyl, their opioid receptors might look like this, occupied by full agonists, and this is need to be really careful to avoid precipitated withdrawal. So this is the part of my sheet that I really advise caution. I advise working with your addiction medicine colleagues if you have them, but really things boil down to some shared decision-making and patient preferences. The options that we have are nuanced, but put simply, we can either wait for opioid withdrawal to develop, then we know again that our patient's receptors are empty, and we can start with a high dose induction or their prior dose. Or we can use a low dose induction while the patient is not in withdrawal and monitor them very closely. We also could always treat pain or temporizing withdrawal symptoms with full agonist opioids, hold the buprenorphine, and defer induction until later in the hospital stay. And if precipitated withdrawal does happen, I don't want you to panic. It can be managed, and I have some resources I'll share at the end about that. So to close our case out, for our patient, we'll say that that fentanyl use 12 hours ago was a one-off. It had not been on ongoing use. And so now 12 hours later, she's starting to have some opioid withdrawal symptoms. Her COW score is 15. Her receptors are therefore empty, and it's safe to resume her buprenorphine. She has relief of her withdrawal symptoms, and she's so grateful to you. So in summary, precipitated opioid withdrawal is harmful. It's a thing we do for no reason. It's due to those two key properties, the high affinity and the partial agonist binding at that mu opioid receptor. We should consider how the mu opioid receptors are bound to guide us and participate in shared decision-making with our patients. And then finally, here's a QR code with the flow sheet and then also the resources that I made about managing precipitated withdrawal. Thank you so much.
Awesome. Great job. Thanks, Michelle.
So I am going to guide us through the chat during the next 2 minutes. So after there was some trash talk between
Uncalled for.
and Florida and all these other things, which, you know, if you know, you know. There was one question for Michelle. Can you just go back and talk a little bit about the fentanyl lasting for the 24 to 48 hours, kind of how that happens and everything?
Yeah, absolutely. So I think, you know, we're all really familiar with
Sorry, I was just referring to the duration of action of fentanyl is so short. I guess if you take it enterally or something, it might last longer, but the duration is the question.
Great.
Yeah, absolutely. And I think this is a confusing point because we are so familiar with using it as a short-acting medication in the hospital. But what happens with, you know, this ongoing frequent use that for patients who have opioid use disorder, who are using fentanyl, you know, days on days, weeks on weeks, it accumulates in the adipose tissue over time, and then it's slowly released from there. So even though the mechanism of action of, you know, a given individual molecule of fentanyl is short, there's kind of a continuous slow release from the adipose tissue that can last for 48 to 72 hours or even longer.
Awesome. Lots of comments for excellent talks, lots of other emojis. One says, "Go mommy, love Mia." So I want you to make sure you saw that one because I would want to see that one. Just scrolling. Michelle Suarez was checking her orders to make sure she was doing things right while you were talking. Any other questions?
We are coming up on time anyway, so thank you.
Awesome.
Great job. Thanks, Michelle.
Awesome. Thank you all.
All right. Next up, we have Dr. Kevin Liu out of Vanderbilt. He considers Alexandria, Louisiana, his hometown, and went to LSU Shreveport. Is that right?
New Orleans.
New Orleans. I'm sorry. I know you said New Orleans in the thing. My bad. And he has been a hospitalist for 7 years. So after I sent the initial questionnaire out for fun facts, we had a great idea that was not just fun facts. So Kevin was subjected to that, which is, what clubs were you in high school? I got to say, this one tracks for a future doctor. Tennis, swim team, student government secretary, but really the kicker was science Olympiad.
Oh yeah, nailed it.
Yeah, just super pumped about that. It's awesome. His walkout song, I'm going to say the name and band, and I am curious who in the audience knows what that song actually is, and you'll know in a second, and you might get to pick a song for the playlist if you know. So it is Serious by the Alan Parsons Project. I'm a little disappointed, Meredith, knowing your husband.
I feel like this is some
Sports
sort of
related.
sports, yeah.
It is the Chicago Bulls theme song from the 90s. And oh my gosh, I still get chills when I hear it. Watching The Last Dance, I could do that all day, Kevin. So you and I, we see each other. Yeah, I guess I should have let more people participate in the chat, but I was just so excited about that one when I saw it. I was like, just good 90s energy here. Okay, so we are going to clear the floor for Kevin for his talk, routine screening for pheochromocytoma and resistant hypertension.
Thank you. Thanks for that introduction.
You made it easy.
Okay. So my name is Kevin Blue, and I'm presenting on things we do for no reason, routine screening for pheochromocytoma and resistant hypertension, representing Vanderbilt. In terms of an outline for what I plan on doing, I'm going to review a very common classic clinical scenario, review over the guidelines, and go over why I think we should stop screening for pheochromocytoma and also recommend what we should be doing instead. Also, I forgot to mention I have no disclosures to share. Just like my photos from my first day of intern year, this scenario comes from my first patient of intern year, which is a 55-year-old gentleman presenting with a past medical history of hypertension, coming in with stroke-like symptoms after getting into a verbal altercation with his neighbor. His intake vitals, blood pressure 186/121, pulse of 92, normal SpO2, temperature of 36.8 degrees Celsius, and a BMI of 32, or what we refer to in Louisiana as skinny. On examination, he's got right-sided weakness of the arm and leg. He's got dysarthria, hemibolismus, and a right-sided gaze deviation. His labs are otherwise unremarkable. And it is important to note that he's on 3 antihypertensives, lisinopril 40 milligrams daily, HCTZ 25 milligrams daily, and also carvedilol 25 milligrams daily. An MRI of his brain confirms that he has a left putamen CVA. Well, what do the guidelines say? The 2020 International Society of Hypertension Global Hypertension Practice Guidelines for Hypertensive Emergency, which is also echoed by the 2020 AHA guidelines as well, is that routine screening should include CBC, BMP, LDH, haptoglobin, UA, urine protein, and urine sediment, and that secondary causes can be found in 20 to 40% of patients who present. Routine screening of secondary causes should include things like hyperaldosteronism, obstructive sleep apnea, pheochromocytoma, Cushing's syndrome, thyroid disease, coarctation of the aorta, and use of certain medications. Well, if the guidelines say that, why should we stop? So I want to review over disease incidence, the test cost, and also the test reliability. In terms of disease incidence, it's 1 in or 2 to 8 patients out of every 1 million persons per year. And that's from Harrison's Guide of Internal Medicine. Roughly, that equates to a 0.01% prevalence amongst all hypertensive patients. So in every 10,000 patients with hypertension, you have 1 pheochromocytoma. But what about the test cost? There was actually a cost analysis done in 2004, back when the test cost around $400. At that time, for every 1 positive test, assuming that 1 in every 2,000 patients with hypertension tested positive, the test cost was around $800,000 per positive test. Well, in 2024, the cost now is $109 for a 24-hour urine metanephrine catecholamine, and that equates to roughly for every positive test, it costs $220,000. To put it simply, none of the screening strategies for pheochromocytoma described are affordable if implemented on a routine basis in extremely low-risk patients, and that was the conclusion from 2004. Well, lastly, what about the test reliability? I mean, we have a 24-hour urine collect, and we have a plasma metanephrine. The 2021 Neuroendocrine and Adrenal Tumor Review article actually goes and says that the sensitivity for plasma free metanephrines has a sensitivity of 97 to 100% and a specificity of 85 to 98%. And the 24-hour urine collect has a sensitivity of 97 to 86% and a specificity of 69 to 95%, which is really good. The conclusion from the study was that both tests are roughly equivalent. Well, unfortunately, later in that year, in August of 2021, a Alberta study actually looked at the sensitivity of the urine collect in a retrospective cohort analysis. In 7,776 patients who were outpatient, inpatient, and ICU, they looked at everyone who had a urine metanephrine study collected and looked at what the test positive value was. And just to put it succinctly, what they found is that in 18.7% of outpatients, in 34.4% of total inpatients, and in 67% of total ICU patients, the test was positive. Patients screened at the threshold. And how many patients actually had pheochromocytoma? 58 out of roughly 7,700 patients. To get to the screening threshold of 98% specificity, the test the urine collection had a sensitivity of at best 59% to at worst 32%. So this test is not reliable. We should flush the 24-hour urine collection down the toilet where it deserves to be. So what should we do instead? When you hear hoofbeats, we were all taught in medical school, when you hear hoofbeats, you think horses. And once you rule out the horses, you think zebras. I like to introduce a third animal called a quagga. Now, the quagga looks like a horse and a zebra. And I want to stress, it's extinct. This animal does not exist in nature. And there is a biotech company right now trying to bring it back, but it is not there yet. So when we think horses, we should think things like renal parenchymal disease, CKD, glomerulonephritis, PKD, hyperaldosteronism, OSA, renovascular causes, and also substance use. I added substance use into horses because the rate of cocaine use in our country has actually increased by 25% between 2017 to 2021. And that's from the CDC statistics before January of 2025. So it's fairly reliable. And unfortunately, what that means is that anywhere between 10 million Americans are using methamphetamine, and roughly 5.2 million Americans are now using cocaine. The disease prevalence of stimulants is around 2 to 5% of our total population. Next comes things like zebras, our Cushing's syndrome, our thyroid disease, primary hyperpara, coarctation of the aorta. And lastly, the quaggas include diseases with such low incidence. Once all zebras are ruled out, that's when we should be thinking about them. And that's where I think pheochromocytoma should be. So in summary, I think we should only screen patients who are at high risk of pheochromocytoma, patients who include a history of pheochromo, which include von Hippel-Lindau, MENs, and then neurofibromatosis. We should rule out patients who have hyperparathyroid or Cushing syndrome first. We should also only evaluate someone who fits the classic triad. And lastly, we should test patients with the plasma-free metanephrines. Flush the 24-hour urine collect. These are my references.
Awesome. Thank you, Kevin. Great talk.
So we will open it up to the chat. I And I hope people start putting in questions. Otherwise, we're going to be talking about quaggas for 2 minutes.
That was fascinating.
Yeah. I have you looked into this success rate for the biotech company trying to recreate this?
So they just successfully brought back the dire wolf. That was from the New Yorker a month ago.
Yep, I saw that one.
The quagga is on its short list. It is not there yet. Maybe in 5 years' time, we'll have a herd of quaggas where I'll have to change my PowerPoint. But as of now, nope.
All right. Everyone's saved by actual questions now. They were too offended by this conversation. So the first question is, how do you deal with the incidentalomas that you're finding, like the adrenal incidentalomas, and considering working those up?
I think that's an excellent question. I think it goes back to whether or not it's important. And with incidentalomas, the disease prevalence of that is fairly high. But again, pheochromocytoma is fairly low. Unless they're still having the classic triad or the full workup has been done, I think hyperaldosteronism is still a more likely disease than pheo. And what brought about this topic was I spoke to a handful of our cardiology attendings who are in their 60s and 70s. And we were talking about diseases we wanted to nail down before we retired. And what was shocking to me is they all mentioned pheochromocytoma. And I've ordered maybe that test a dozen times and gotten 0. And someone told me I've ordered 500 times in my career and still had 0.
That sounds right. So that's a good segue. It sounds like then for the next question, is there any role at any time to really be ordering urine metanephrines, which sounds like leaning towards a no?
I would put that as a hard no. The data is just in my mind conclusively against it. We don't have any data about the plasma metanephrine, and the test I didn't share in my slide, but the test cost is the same. So why would we use an inferior test that is shown to be unreliable when we have a test that doesn't have determined real-world reliability yet?
Great. We have a couple braggarts saying they've seen 1, maybe even 2, Emily from UAB ICU. Yes,
That is
no need for
amazing,
bragging.
and
That is
I
pretty
would
cool.
love to see that.
I would too. Okay, we are out of time, and so we're going to move on to our next speaker, who is Dr. Kara Grace Leventhal from Johns Hopkins. So she is born and raised in Washington, D.C. and went to Georgetown University School of Medicine. She is a PG West 7, very proudly. She has 2, I don't know anything about dogs, Meredith, Cavapoos.
Oh, you have a Cavapoo. That was my first
do.
nephew.
Wait, what?
Yeah, one of my friends has one. It's Cavalier King Charles, and what's the other half?
Poodle. They're
Poodle.
both toy poodles. They're adorable and don't shed, so that's nice.
Yeah.
Great. I think you sent me a picture of the dogs, but it has been left out the slides. I apologize, because you have descriptions on the left and right. Your walkout song, I've been waiting for someone to have some Lizzo. About damn time someone pick Lizzo.
That would be your number one concern on this.
It really would be. I mean, Lizzo is she's a hype woman for everybody.
Yeah. In case everyone didn't know, when you submit your songs, Moni's just sitting here judging you.
Okay. No need for that. All right. We are going to give the floor to Dr. Kara Grace Leventhal from Johns Hopkins for her talk, Choking Hazard, Things We Do for No Reason in Aspiration Pneumonia Prevention.
Thank you so much. All right. Okay. Oops, there we go. All right. Well, thank you again so much for having me. I've been really looking forward to this all week. And I love talking about aspiration pneumonia prevention. I do a lot of work here at Hopkins in that space. So after the talk, if anyone wants to talk more with me, please reach out. I'm hoping that at the end of these few short 8 minutes, you'll be able to identify the pros and cons of using thickened liquids for aspiration prevention, and also teach others about what are some high-value practices to reduce the risk of aspiration pneumonia. I'm going to start off here with a case. You have a 79-year-old woman that you're admitting who came into the emergency department with 3 months of worsening persistent cough and fatigue. She did feel better for a brief period of time around a month ago when she was on a short course of antibiotics, but then had recurrence and worsening of her symptoms. Her husband says that she seems to cough more when she's eating and drinking. You check her vitals, notable for a fever, mild tachypnea, and hypoxia. And on your exam, it looks like she's got some poor dentition and reduced lung sounds bilaterally. You have your suspicions, but you get a chest x-ray to confirm. And sure enough, it does show that she has aspiration pneumonia. So she's admitted to the hospital, started on antibiotics, and then given the history you got from the husband, you consult SLP. And they do a video fluoroscopic swallow study. And sure enough, she is aspirating on thin liquids. So they recommend that she get thickened liquids instead, because when they did the video fluoroscopic swallow study, she didn't aspirate as much with the thickened liquids. So you do that, you start her on the thickened liquids. She's getting better. You're even starting to think about discharge when you're paged to bedside. Your patient's confused and agitated. You go to see her. You notice that there's several unopened containers of thickened water at bedside. And her daughter tells you, yeah, she's really not been eating or drinking very much. She hates that thickened liquid. So you have your suspicions, but you check some labs, and it does show that she's got an AKI and hypernatremia. So it's confirming your suspicion that this is dehydration. But you stop and think to yourself, what's going on? I was doing all the things that I was supposed to do to take care of this patient, and she got worse. Why? Well, let's pause here to take a moment to talk about thickened liquids. I think this is something that probably all of us have ordered for our patients. I personally have not had the pleasure of tasting them, but I have not heard good things about what they're like. But if we're using them, there has to be a good reason why we're doing it, right? So I'll start off by going through some of the pros of thickened liquids. I want you to reach back to pre-med physics and think about how the higher viscosity of these thickened liquids is going to lead to slower flow. That slower flow is going to allow for more time for airway closure, reducing the risk of aspiration, okay? And just like for our patient, when they do video fluoroscopic swallow studies, they do see that the use of thickened liquids improves the results for aspiration. In a study of patients at high risk for aspiration, initially 16 to 20% of them were aspirating thin liquids. When they used nectar thick, this went down to 8 to 10%. When they used pudding thick, it went down to 3 to 5%. So those are some pretty impressive numbers. I can understand why our SLP colleagues are recommending it. But what are some of the downsides? Well, like what happened to our patient, a lot of folks get dehydrated or even get a UTI compared to thin liquids. They don't posit in the article about the reason for the UTI, but my thought being, if you're dehydrated, your urine is sitting in your bladder for longer, there's more of an opportunity for that bacteria to grow and a UTI to develop. The perceived quality of life for patients too is just significantly lower. And as a result, only about 30% of patients who are prescribed thickened liquids are still using them after the first week. So in conclusion, most important, this is really something that we kind of do for no reason. There was a comparative effectiveness trial of stroke patients, and they found that family instrumentation on swallowing techniques without the use of thickened liquids was just as effective as the use of thickened liquids. There was no increased risk of pneumonia, dehydration, or malnutrition, just teaching families and patients about different swallowing techniques, which I'll talk about in a minute. There are follow-up studies, including meta-analysis, again, finding no statistical significance in the risk of developing aspiration pneumonia in patients who had access to free water compared to patients who were on thickened liquids. The one little asterisk I'll put for this here is that these studies did have very strict exclusion criteria. So they didn't include patients with impaired cognition or mobility limitations. So there may still be a few patients that we take care of that would benefit from the use of thickened liquids. So to switch gears, let's talk about what does work. This is going to sound incredibly simple, but these are the two of the interventions that have been shown to be the highest impact. So just doing the chin tuck or chin down position is just as effective as use of thickened liquids and has no side effects associated with it. And then if you want to lower your patient's risk of aspiration pneumonia, you should be brushing their teeth. Ideally 3 times a day if they're high risk, but even doing it twice a day is going to reduce the risk of pneumonia by about 15%. Something that surprised even me is they did this very creative study in Japan where they combined 4 RCTs looking at oral care and pneumonia and did a systematic review. And they found that about 1 in 10 deaths from pneumonia in elderly nursing home care patients could have been prevented if they had adequate oral care. There are not many things that we do in medicine that can show those kinds of results, and this is something that all of us can do and tell our patients and their families about. So let's go over some take-home points. First and foremost, I want you to recognize when your patient is at high risk of aspiration. Think about the woman that we started with. She was older, she had an esophageal disorder, GERD, she had a neurologic disorder, prior stroke, and she also had poor dentition. And then once you recognize your patient is at high risk, take steps to reduce their risk. Do some oral care with them at least twice a day, if not twice a day, 3 times a day. Work on swallowing rehab and training, and elevate the head of bed to 30 degrees. And with that, I will stop and thank you all so much again for the opportunity to talk with you today.
Great talk. Thank you so much, Kara Dreas. And they call you KG. Is that what I hear?
Yeah.
All right, cool. Thanks, KG.
So already questions in the chat, which I love. So they're kind of both in the same vein actually. But we'll go with the first one. When they were looking at aspiration risk, did they notice much difference like with mildly thickened being 1 packet, but more of a difference with moderately thickened products?
They didn't comment on that. They didn't separate out like nectar thick versus pudding thick. They just classified it as thickened. So I would assume nectar thick, but I'm not sure.
Okay. And then the second question is, was there any suspicion that the reason there's no difference is because people don't actually adhere to the thickened liquids?
That's a good point, but the studies that they did show people were following people who had adhered to the thickened liquids.
Got it.
Yeah.
Lots of great talks, excellent talks, awesome review. How do you have your discussions with SLP when they're recommending thickened liquids and you're not?
Yeah, I think that's tricky. I mean, thankfully there is this article that's been published, so you can take it with you. Here's a published article about things we do for no reason in thickened liquids. They're well aware that patients don't like it. And that, as I tried to highlight, there may be a few select patients where the risks or the benefits are more than the risks. But I think overall, just kind of having a shared decision and explaining, I'm not just ignoring your recommendations entirely. I would love for you to work with them on swallowing techniques, would be kind of my approach.
Awesome. I agree, Michelle. This is an interesting interprofessional problem, as is many things in hospital medicine.
And really the entire Things We Do for No Reason series.
Yep. And with that, I think we're at our 2 minutes actually,
Yep.
so we can go on.
We are. All right. Next up, we have Dr. Caroline Coleman out of Emory. I will try not to sound biased. She is from Orlando, Florida, and she's been a hospitalist with us here at the VA close to just over 2 years.
Under 2 years.
Under 2 years. I can't do math. She, after SHM, was the smart one of all of us and actually did a vacation and went to what she called an out west trip. So Bryce, Zion, and Grand Canyon National Parks. Caroline, what was your favorite of that trifecta?
This picture was from Zion, which I took specifically for y'all, so please enjoy. But I think we liked the Grand Canyon the most. It's one of those places you take a picture and it doesn't even capture it.
Yeah. Also, that doesn't capture anything, your theme song, American Idiot, by Green Day, if anyone is not familiar, one of the best albums to come out in 2004, and a great song. All right, so Caroline's going to be doing Things We Do for No Reason, avoiding IV iodinated contrast and AKI or CKD.
Is this showing up right?
It's not in presenter mode or presentation mode yet, just
I know that little button's not working. Let me try again.
As the certified boomer of this group, you might have to go to the top, drop down menus if that one's not
Oh.
working. And if this works, I'm going to totally take all the credit.
Let me try this way.
That did not work. You made it worse.
How about this one?
I can see your notes. You're like in presenter mode.
Oh, grats.
Don't worry, I did that during my
I'm the
presentation
boomer.
and didn't realize it.
Yeah, we get mocked for our boomerisms, Meredith.
What about this one?
There we go.
Nailed it.
Nailed it. All right. Thank you everyone for your patience. I am now the resident boomer. Caroline, thanks for being here. And like Moni said, I'll be talking today about a thing we do for no reason, which is avoiding IV, not intra-arterial, iodinated contrast material, henceforth just called contrast, in patients with either AKI or CKD. So our learning objectives today are threefold. First, we'll talk about why we are all so afraid of IV contrast and think avoiding it is safer. Then we'll explore the 4 reasons that we really don't need to be afraid of it. And then lastly, what we should be doing instead. So to start with why we're all afraid of IV contrast. Well, we use a lot of it, so we really need to know the risk. In 2003, over 80 million doses or 8 million liters of this drug was given. For my Atlanta folks or anyone who's been to the Georgia Aquarium, this is equal to the volume of the beluga whale exhibit, plus the volume of the Shark Tank exhibit, plus the great whale shark exhibit. And by volume, this is likely the most given drug in the world. And this also has been around in medical lore for all the way back to 1954, which is when the first case report was written. And in fact, the contrast dye used back then probably was poisonous. It was a high osmolar dye that no one would imagine using today. But even with the advent of newer, safer contrast dyes, this data has persisted. And a series of well-done randomized, not controlled, and we'll come back to that, but randomized trials in the 90s and early 2000s found this AKI rate after contrast of anywhere between 2 to a whopping 27.8%, which is scary and why we're all afraid of IV contrast. But let's now go through the 4 reasons that the modern hospitalist does not need to be afraid of contrast. The first is that contrast likely correlates with, but doesn't actually cause AKI. Let's explore that a little bit more. So we all assume the mechanism's this. Patients get admitted to the hospital, they get contrast, and contrast causes the AKI. And indeed, many studies show that that contrast is associated with increased AKI, like the studies we were talking about in the 90s and 2000s. But those studies were not looking at the question we're asking today. They were looking at contrast versus a different flavor of contrast, not contrast versus a control group. Again, they were not asking, does contrast nephropathy exist at all? So some people took a little bit of a closer look. In 2008, a single center study looked at hospitalized patients who received no contrast, but they were being clever. They wanted to see if AKIs still occurred that met the threshold of contrast nephropathy in these patients. And what do you know? They found creatinine increases that were the same as previously published rates of contrast nephropathy, around 25%, again, in patients that didn't actually receive contrast. And what they were trying to look at is, wait, maybe these patients, our hospitalized patients, just experience a significant baseline rate of AKI, regardless of whether they get contrast. And we all know this to be true. Sick patients get admitted to the hospital and sick patients develop AKI. So this is interesting, but still, we need randomized controlled trial data to answer this question. So in 2017, we got that. There was a systematic review and meta-analysis of several RCTs of folks that got admitted to the hospital for a stroke workup. So they got their CTA head and neck, so they got contrast. But what they found, astonishingly, is that these folks had fewer AKIs. And we all know, I'm not here today to tell you that contrast is renoprotective. That's not what's going on. But what's happening is that hospitalists are ordering these contrasted studies on healthier patients, and healthier patients have fewer AKIs. We call this selection bias to explain this surprising finding. So where does this leave us? Everything is riddled with bias. We have no idea where the data stands. And without a randomized control trial, we're left with some clever statistical methods to try and control this bias. One of the best ones we have is something called propensity score matching. And a couple of studies in the late 2010s looked at this question again with propensity score matching, and they found no differences in AKI rates between folks that did or did not receive contrast, even when stratified by GFR, so even into CKDs 1, 2, and 3. Another large data set with almost 6 million hospitalized adults found, again, that surprising finding that folks that got contrast had fewer AKIs. And what the authors concluded is that, quote, the relation between radio contrast administration and AKI is highly confounded, unpredictable, and sometimes bidirectional. It doesn't get more wishy-washy than that. Even the New England Journal saw this, and they changed their review on the topic to a title of contrast-induced nephropathy in 2006, walked it back to contrast-associated nephropathy in 2019 because of this data. The next reason that you need to not be afraid of contrast is because the pathophysiologic basis is really shaky. Researchers fall short of calling this acute tubular necrosis, or ATN, due to some inconsistent clinical features like recovery of creatinine within days instead of the normal weeks for ATN. Second, researchers have these savvy little renal biomarkers like a troponin for the kidney that are clinically unavailable. But in research studies, they're able to look at these renal biomarkers in patients that have a rise in creatinine, and they see no change in the renal biomarkers, begging the question of whether an actual cellular level injury is occurring. Third reason you don't need to be afraid of contrast is even if there is a slight rise in the creatinine, there's very rare patient-centered renal outcomes like need for dialysis. The data we have to assert for this is 2 randomized control trials that were done exclusively in folks with CKD3, who we might think are the folks we worry about the most. And they found no significant difference in the rates of AKI, progression of CKD, or need for dialysis after contrast. And I know some of y'all are thinking, you know, Caroline, this is all cool, but I would still rather be safe than sorry, right? And I'm here to remind you that there is a risk of withholding contrast and causing potential diagnostic delays or worse clinical outcomes for your patients. While we don't have compelling evidence for this in the IV contrast world, there is data in the intra-arterial contrast literature that does show this. For example, in a study that looked at patients with CKD who came in with an active MI, they received fewer left heart casts, so less intra-arterial contrast, and at a higher mortality rate at 1 year from cardiac causes, showing that there is a risk when we don't order contrast. So you might be thinking, okay, what the heck should I do instead? And believe it or not, the radiologists and the nephrologists agreed and wrote up a consensus statement in 2020 saying that we have likely overinflated the risk of contrast nephropathy greatly. And they gave some practical recommendations for the hospitalist. The first is in life-threatening scenarios, do not withhold contrast based on GFR. The risk is so low and the risk of your life-threatening scenario is too high. Second, you can consider prophylactic fluids for patients who are not at risk for fluid overload if their GFR is less than 45, but it's a low quality recommendation because they don't know the timing, the amount, the rate of the fluids to give. And lastly, the big take-home point is for our routine clinical scenarios, when you go to work tomorrow and see patients, for a GFR over 30, they recommend not withholding IV contrast. And for a GFR less than 30, due to some limited data, you can consider the risks and benefits, but it's not a hard stop. I'd like to thank the folks that helped me make this presentation and write up this Things We Do for No Reason article, and to review the publication that got published a couple of weeks ago. You can scan the QR code below. Thanks for listening.
Thanks, Caroline. Awesome job.
Yeah, I will get us started in the chat. I will say, embarrassingly, I pre-hydrated someone that didn't need to be today to get my CT done. Lots of great talks, great presentations. Can't believe radiology and nephrology agree on anything.
The darndest of friends.
You know. More great jobs.
Just the Emery warm hug, as I like to call it.
Anything?
Any questions?
Everyone's going to do it now, even though I can't, and I'm on this paper.
What was our resident favorite nephrologist's opinion on the paper? That would be my brother, for the people that don't know.
He did agree with it.
Yeah, mostly.
Yeah, mostly. There was some hedging, but we're all doctors. We all hedge.
I think he just lives in perpetual shame that his sister wrote a paper that told him that he needs to stop worrying about the kidneys.
Yeah.
So
it's called brotherly love. Dan Dressler would like to know, love the data. How do you communicate with your radiologists when they are contrarians?
Something I've done is previously, this sounds a little spicy, but even just cite that consensus statement and just say that, I think that the benefits of the CT exceed the risk. Doesn't work all the time, but I think having the consensus statement between the kidney doctors and the radiologists does go a long way.
Awesome. Mark Williams said, tell them you're a hospitalist and you know better.
Brr.
Oh man, I think that's going to go over really well.
Yeah, they'll love that.
All right. Awesome job, Caroline. Thank you. We're gonna keep things moving. We're actually moving a little ahead of schedule, which I much prefer. That's always particular about my time. All right. Next up, we have Dr. Erin Dyer, who is joining us from WashU in St. Louis. She grew up in Oxford, Mississippi, and went to med school at the University of Mississippi Medical Center. Erin, I didn't get to ask you, did you train at Mississippi or WashU?
I did residency here at WashU.
Did you know Amanda Clark or Trey Clark when you were at Mississippi?
I knew Amanda a little bit, yeah.
Oh, she was my senior and also a chief resident of mine when I was at UAB. So
Cool.
Warm hug for me.
Yeah.
Cool. This is your first year as a hospitalist. And then she also got the clubs while one was in high school question, Meredith. She was on the tennis. That's a pattern I've noticed. The tennis team seems to come up a lot. What do you think that is? What that's about?
I don't know, because I didn't play tennis. I played golf. I was captain of the team, not to brag or anything.
It still shocks me that you played golf, knowing your coordination or lack thereof.
There was no try.
Oh boy. Okay, well, before we get too sidetracked with that, so Hit Me With Your Best Shot by Pat Benatar is Erin's walkout song, which is a great choice. I'm gonna put myself out there a little bit and embarrass myself. I did not know this song until it popped up in one of the medleys in Pitch Perfect in 2012. So not embarrassed to admit it, that my pop culture knowledge really comes from weird places.
Coming from Pitch Perfect is not weird.
Yeah, but like
the delay, the delay is what's weird.
Yeah, the delay. I mean, Pitch Perfect or American Idol, take your pick. Okay, before we get too sidetracked, Dr. Erin Dyer's presentation is CT or not CT, neuroimaging for the hospitalized patient with delirium.
How's that look? Good, okay. Well, thank you so much for the introduction. I'm really excited to be here and be connecting with all of you across the country. So yeah, my talk is titled CT or not CT, that is the question. And I'll be talking about neuroimaging for hospitalized patients with delirium. And we'll start with the case of Mr. Jones, who is an 81-year-old male. Oh, sorry. Is an 80-year-old male with a history of AFib on anticoagulation, BPH, and mild cognitive impairment, who was admitted about 3 days ago with pneumonia. You go see him on morning rounds, and he's more drowsy than he has been before, and he's only oriented to self when normally he's oriented times 4. And then his nurse tells you that last night he was trying to get out of bed several times and was saying that he needed to go feed his dogs. So at this point, I would ask you the question, if you were the one taking care of Mr. Jones, do you think that you would order any kind of neuroimaging to further evaluate his change in mental status? I hope that by the end of this talk, you'll be able to answer that question and hopefully be able to describe some of the limitations of neuroimaging for evaluating delirium, and also to identify at least 3 reasons for obtaining it for a hospitalized patient with altered mental status. I know we've all taken care of patients with delirium, but just to kind of get us all on the same page to start, I want to emphasize that when we talk about delirium, we're talking about a disturbance in consciousness and a change in cognition that develop over a short period of time. And there's just a pretty much never-ending list of provoking factors and disease processes that can cause delirium, including intracranial pathologies. And so often when we start that evaluation, looking for the cause of a patient's delirium, we consider doing some kind of imaging. And we're looking for things like this. We're looking for strokes, for bleeds, maybe for a mass or signs of infection. And all of these intracranial processes can present to varying degrees with delirium. And they're things that we don't want to miss because potentially we could intervene on them. But it's really important that before we order that test, we really understand what we're going to do with the results or how good the test is at finding what we're looking for. And so I'll use the example of the good old non-contrast head CT, which I think is often the go-to choice for many of us in this situation. And I'll tell you that the sensitivity of a non-con head CT for acute ischemic stroke is really poor. It's only about 15%. CT does a lot better for intracranial hemorrhages with a sensitivity of about 90%. But it's just really important for us to remember those test characteristics so that we know how to accurately interpret the results. And beyond the limitations of the tests themselves, there are other drawbacks that we need to consider. For instance, the cost of the scan. The average non-con head CT is about $1,300. There's, of course, the radiation exposure that comes from a CT scan. There's the potential that performing the scan itself can lead to worsening delirium. If you think about having to transport your delirious patient down to the scanner, maybe give them some kind of sedation or use restraints to help them tolerate the test. And then there's always the possibility of incidental findings that can lead to more expensive and probably unnecessary workup. And so at this point, I want to share the results of a couple of studies that looked into this topic that I really think help to paint the picture of how useful the head CT is for evaluating delirium. And this first one is a retrospective study out of Australia, where they looked at 300 patients that were on a specific delirium unit. Out of those 300 patients, 200 of them had a head CT performed to evaluate for the cause of their altered mental status. And then these were the results. They found that 85% of the CTs were normal, 6% showed an ischemic stroke, 4% showed a subdural hematoma, and 5% showed an intracerebral hemorrhage. And when they further analyzed their data, they found that there was a statistically significant association between a positive CT result and one of these three features highlighted here. So a new focal neurologic deficit, a significant deterioration in consciousness level, and a recent fall. And they found that actually 90% of the patients in their cohort who had a positive CT scan met at least one of these three criteria. This is another study, another retrospective study of patients on a medical floor. They found 398 head CTs that were performed for an indication like delirium, altered mental status, or encephalopathy that developed more than 24 hours after admission. And then they specifically excluded patients who had a new focal neurologic deficit, a recent fall or head trauma, or an admission diagnosis of intracranial pathology. So really trying to narrow down to that low-risk population of patients. They ended up with 220 CT scans that they examined. And out of those 220, they found only 6 positive scans, so 2.7%. And half of those patients, so 3 out of the 6, were on anticoagulation. So they determined that in that low-risk population, the yield of the head CT was actually quite low. And they suggested that maybe anticoagulation is something that we should factor into our decision about getting the scan or not. So putting all of that together, when should we get the head CT? I think without a doubt, in a situation where you have a new focal neurologic deficit or a recent fall or head trauma, we should absolutely get the scan. But there are some other situations where it might be appropriate as well, including if the patient is on anticoagulation, if there's a really significant decrease in consciousness level. The study I mentioned earlier, they used a GCS score of less than 9. If there's something about their medical history that puts them at higher risk, so for instance, if they have a malignancy and they could potentially have brain mets. And then finally, in situations where either the delirium is not improving or the etiology is just still really unclear, that's a time where you can consider imaging as well. And so I'll end by circling back to Mr. Jones. And what should we do about Mr. Jones? Well, I think for starters, we should absolutely do a good neurologic exam and look for any kind of focal deficits. We should take a good history and see if maybe he fell last night when he was trying to get out of bed. We should use a validated assessment tool like the CAM or the months of the year backwards to really confirm our suspicions about delirium. And then we should think about all the other potential causes of his altered mental status. So look at his med list, think about things like urinary retention, constipation, or infection, all those other things that might be more likely than an intracranial process to be causing his delirium. And so with that, I'll say thank you to Emory for hosting this event, to Dennis Chang, who encouraged me to participate and mentor me through this, and to our division chief, Mark Williams, for his support and leadership. Thank you so much.
Great job. Thanks, Aaron. And speaking of Mark Williams, he had a great question.
What is going on in Australia that they have a delirium unit with 300 patients?
That's a great question.
I honestly feel like if you've been to Australia, it makes sense.
I've not. Please elaborate.
Lots of great talks. Have you had any times when you really wanted to send a head CT but didn't because of this?
I have a few delirious patients on my list right now. I think what I learned from doing this research is I'm just much more reassured by my own neuro exam. And so if it's just, they're a little sleepy and they don't know where they are, I feel a lot more reassured about not ordering that test.
Awesome. How do you talk to nurses who really want the CT?
Another interprofessional problem. I think, kind of explaining, what things we would actually maybe see on the CT and how our suspicion for those things is pretty low in a given patient might be helpful.
Yeah, that's typically my philosophy is word vomiting to the person my thoughts and hoping that they can interpret what I'm thinking about.
Or there's so many thoughts that they're like, I don't want to keep talking to this one. Fine, she can have it.
Mark Williams says, do not tell them you're a hospitalist and know better. Agreed. That would be poor form. I think we forgot to start the timer.
We always do.
Okay.
Okay. We're doing okay on time in general.
Um,
Any other questions? All right. Great job, Aaron. Thank you so much. All right. Next up, we have Dr. Amiran Badushvili out of University of Colorado and Denver Health. His hometown is Rustavi, Georgia, the other Georgia. He made sure to clarify. He's currently in Denver. He went to medical school at Stony Brook in New York. He's been a hospitalist for 11 years. He was a soccer player. That's, in high school.
Because he was popular, probably.
Probably very well liked. And look at that jersey. And the kids are in jerseys in the picture. I mean, just lots of adorableness happening there. So your walkout song is Feel Good Inc. by Gorillaz. If any of you listen to the podcast, and if you don't, you should. It's called 60 Songs That Explain the 90s, the 2000s. It's a quirky dude that hosts it. That's why it's called that. He had a 90s series before. They just did an episode on this song. And it's just fascinating to hear, he goes through the history of the Gorillaz and a little bit before. Such a great song, such a great background. Highly recommend. And it's a great song if you're not aware. All right. So his talk is Dr. Amiran Badushvili's talk is from Binary to Better, Rethinking the Diagnostic Test Interpretation.
Right. Thank you so much for your kind introduction. All right, so we'll get started. I do have one disclosure. I am a founder of EBM Clarity, which operates an online course in Bayesian reasoning. This presentation does not reference, include, or promote this course in any way. All right, the learning objectives. I hope by the end of this talk, you'll recognize the limits of binary diagnostic test interpretation. You'll understand how interval likelihood ratios offer more nuanced diagnostic insights and help us make better decisions, and apply interval likelihood ratios to a few patient cases. So let's get started. You are seeing a 51-year-old woman who's coming in with chest pain after doing some exercises in a gym, and she has no past medical history. Vitals look pretty normal. After you finish your evaluation, you think she has low pretest probability for PE. So you get D-dimer, which comes back elevated at 600. So do you proceed with CTA? Well, first, let's ask how positive D-dimer affects P probability. So this is everyone's favorite nomogram, I'm sure. which helps us calculate this. So here is the pretest probability, about 5%. We mark in the middle likelihood ratio, we connect the dots and get post-test probability. But what if this patient's D-dimer was 16,000? Well, we start with a 5% pretest. It's positive, so we use likelihood ratio of 2, connect the dots, and get 10%. You're probably looking at this and thinking that can't be right. There has to be a mistake somewhere, and you are very much right. There is a mistake to assume that D-dimer of 600 and 16,000 are the same kinds of positive, and BNP of 200 and 10,000 are the same, and so on. Yet, this is exactly what we do when we draw a line in the sand and split results into positives and negatives. And to stay with the theme of the day, I guess that's one of the things perhaps we do for no reason. Is there a better way to do this? Sadly, no, we are doomed into positives and negatives. Just thinking, there's one way, and that has to do with better understanding of likelihood ratio. So what is likelihood ratio? It's very simple. It's just a ratio of two likelihoods. And what are those likelihoods? Well, on the top, we have the probability of patients with disease having a specific test result. And at the bottom, we have the probability of patients without disease having that same test result. Simply put, we are asking, is this test result, positive, negative, or whatever, more common in patients with disease or without disease? For example, if you are interested in likelihood ratio for positive JVP, we would want to know how often do patients with CHF have elevated JVP, about 50%, and how often do we see elevated JVP in patients without heart failure, about 10%. So that gives us likelihood ratio of 5. That means a positive likelihood ratio is 5 times more common in patients with heart failure. So how does that help us? It helps us reframe the question we want to ask. We want to know, how does D-dimer of 600 affect probability of PE? In other words, is D-dimer of around 600 more common among patients with PE or among patients without PE? And this is exactly where interval likelihood ratios become super helpful. So here is data from a large meta-analysis. Turns out D-dimer of around 600 is found in about 5% of patients with PE and 16% of patients without PE. This supposedly positive test is more common in patients without PE, has interval likelihood ratio of 0.3, therefore it lowers PE probability. And here are the rest of the interval likelihood ratios. As you see, these likelihood ratios span narrower test ranges without combining a large number of results into one bucket. And you can simply use the one that matches closely to your patient's results. I mean, how cool is that? So with binary or dichotomous interpretation, we're committing to extra testing. And with interval likelihood ratios, we can spare our patient unnecessary contrast and radiation. What I suggest here, by the way, is backed up by the evidence. Here is a Canadian study where they had over 300 patients with low pretest probability for PE with D-dimers between 500 and 1,000, supposedly positive. None of them ended up being diagnosed with PE. All right, now that you have acquired interval likelihood ratio superpowers, let's try this again. Apply it to another case. This is a real patient, by the way. 49-year-old man, Mr. V, comes in with lower extremity edema, hypoxia, cardiomegaly, and chest X-ray. You think the CHF probability is roughly 80%, but BNP comes back pretty low at 14. But your colleague tells you, don't worry, the patient's BMI is 37. BNP is pretty much worthless here. Does it sound familiar? Likely. Is it true though? Let's see. So here are the interval likelihood ratios broken down by BMI. Turns out for his result and for his BMI, likelihood ratio is 0.1. Seems kind of useful. In fact, it reduces probability for CHF down to 30%. So what happened to Mr. V? He got diuresed, he got worse, but a hospitalist with a point-of-care ultrasound came and saved the day. She diagnosed him with cardiac tamponade, had 1.3 liter drained from his pericardium and ended up doing great. So once you start thinking about interval likelihood ratio, you see their value everywhere. Here is hit antibody for dichotomous and interval likelihood ratios. As you see, the supposedly positive results span ones that reduce probability of disease versus ones that are virtually diagnostic. Here are ones for Light's criteria. As you see, a lot more nuance when you look at interval likelihood ratios. So take home, binary test characteristics combine very wide range of test results into one, and that can waste diagnostic information. And interval likelihood ratios use narrower ranges and more precise and help us make better decisions. By the way, how cool would it be if we had this at point of care in EMRs? And I hope that's something we can aspire towards in the future. Here are the references, and this QR code has access to the slides, and also I compiled a table with interval likelihood ratios for a bunch of studies, and you can keep that as a reference and use them in your practice. Thank you.
Awesome. Great job. Thanks, Amiran.
Yeah, that's a great talk. Annie Massert opening up the warm hug of excellent presentation. Anyone can put in their questions into the chat at this point. Kevin is asking, is there a repository of ILR for all lab findings, i.e. D-dimer levels and PEs versus malignancy?
Unfortunately, no. And I hope that's something that I can contribute to with perhaps some of you to develop such a resource. I think it would be really useful for us to have easy access to different tests, and especially in different populations. As you saw, it's important to think about variables like BMI and how they modify test characteristics. So cancer can modify the test characteristics of the dimer, and having interval likelihood ratios specifically in that population would be very, very useful.
Yeah, it's kind of interesting. I wonder if it would almost be more effective than like when they were doing the cost pop-ups in EMRs to see if that like avoids testing in a way.
Yeah, it seems like there needs to be an app for that.
You working on that? Okay. All right. The next question, how would you help people to set a pre-test probability?
Oh, that's a great question. So a few things can be helpful. So first, for starters, disease prevalence, right? So going back to Kevin's presentation, thinking about how uncommon pheochromocytoma is, no one will likely have a pretest probability of 50% of pheochromocytoma, right? Because it's simply an uncommon. Even if they have all the other symptoms that are consistent, it will still be low. So overall epidemiology of disease is a good anchor. And then we, on top of that, can layer patient-specific factors. So do they have certain risk factors that increase the probability or decrease the probability? So you can adjust the overall prevalence based on those. So those are probably sort of starters. And at the end of the day, if you ask 10 different attendings to give you pretest probabilities, there will be variation. But oftentimes when you apply diagnostic tests and calculate your post-test probabilities, the decisions you make at the end don't vary unless you have a really big disagreements in pretest probability. So if you are in the ballpark, you'll probably be making similar decisions, even with a little bit of variation.
Awesome.
Super helpful.
I think that's the end of our Q&A time. So I think you're going to the final
countdown to another callback to another legendary sports team, the Detroit Pistons. Final countdown by Europe. Anyone? Yeah. All right. Our last speaker is Dr. Glenn Carman out of the University of Alabama, Birmingham. He is from Baton Rouge, Louisiana, and he also went to LSU New Orleans School of Medicine. He had a cool one. He played Ultimate Frisbee.
I was an ultimate frisbee person. I played in college and I actually played 3 times a week during med school. I found a local pickup group and I played with my med school class. So fun facts about Meredith.
And we're gonna get to some more later. But yeah, no, that's awesome. And then choir. Glenn, do you recall a favorite song from choir at all? Or do you just block that out?
The names of these songs are so incredibly generic. They're mostly liturgical and the name of a psalm or something. That's mostly what we sang.
In Louisiana.
Yeah, believe it or not, I sang in the Catholic Church a lot. There's a few of those in South Louisiana, so it was a lot of Latin. But I just, it was all great. I loved all of it.
Gotcha. And then fittingly for his Louisiana roots, theme song or walkout song is Louisiana Saturday Night by Mel McDaniel. Good choice. And rounding us out, Dr. Glenn Carmen with Down the Wrong Pipe, Rethinking Anaerobic Coverage in Aspiration Pneumonia.
All right. All right, bear with me here. All right. So today I'm going to talk about aspiration pneumonia and rethinking our use of anaerobic coverage in treating it. So my objectives today, we're going to look back a little bit on the history of covering anaerobes and aspiration, and talk about the guidelines and talk about some more current evidence to help guide our decisions for treatment. So we'll start with a clinical case. So we've got a 75-year-old lady. She's got a history of an MCA stroke and dementia. She's brought in from her nursing home to the emergency room with confusion and cough for the last 12 hours. She has a fever to 101 degrees Fahrenheit. She's setting 93 degrees on 3 liters of oxygen by nasal cannula, normally on room air. And she's found to have a leukocytosis with a white cell count of 14,000. So we get a chest X-ray. And what we notice is that there's a right lower lobe opacity, and she's diagnosed with pneumonia. So ceftriaxone and azithromycin are started per the guidelines for community-acquired pneumonia, and the ER admits her to the floor. So the admitting resident, when they're checking out to you, asks if they should cover for anaerobes, as they suspect that this patient aspirated. So a few things about aspiration pneumonia. Aspiration pneumonia, simply defined as a bacterial lung infection due to aspiration of gastric or oropharyngeal secretions. This is thought to make up somewhere between 5 and 15% of pneumonias, and it is associated with an increased mortality, significantly increased mortality compared with CAP without aspiration. It is more common in institutionalized elderly. Now, a challenge with aspiration pneumonia is that diagnostic criteria are not consistent across the board, and generally the diagnosis is made based on the perceived risk factors that the patient has. But the question is, why are we covering for anaerobes in aspiration pneumonia in the first place? And like a lot of the things that we do for no reason, the answer goes back to the 70s. So there was a study back in the 70s looking at penicillin G versus clindamycin in aspiration pneumonia. It was a retrospective cohort study, only had 84 patients. They were identified as having either pneumonitis or abscess, and they were treated with penicillin G or clindamycin. Simpler time. No difference was found between the treatment groups. And there was no difference even if they had abscesses or were found to have bacteroides on culture. But across the board, these patients had very high rates of anaerobes. Over half of them had anaerobes cultured. Now, some criticisms of this study that have come out much later, really just the high rate of abscesses that these patients had. Almost a third of them had abscesses, which is much higher than what we might see today. Cultures were taken late in the clinical course, and the way the cultures were obtained was using this transtracheal aspiration, which you probably have not seen in your own practice if you're trained when I did, but it actually involves placing a needle through the skin and directly into the trachea to get an aspiration. So a lot of time passed, and we decided to take the lesson that there were a lot of anaerobes present rather than the actual outcomes of the study. And that's what drove a lot of our practice. So as early as 2001, the guidelines were telling us that anaerobic coverage was indicated for all patients who had aspiration risk factors or were living in a nursing home. And then if they had cultured an anaerobe, they should be specifically on clindamycin or metronidazole. 2001, new guidelines, but they did not address anaerobic coverage at all in aspiration pneumonia. But then finally, 2019, we get a recommendation against routine coverage of anaerobes in aspiration pneumonia, unless there's an empyema or an abscess. However, there was limited data for this. So the rationale for the 2019 guidelines, sort of what changed. So there were several studies since 2001 that have showed that anaerobes really are not nearly as common in pneumonia as we used to think. A 2003 study of institutionalized elderly patients presenting to the hospital with aspiration pneumonia showed that only around 16% of cultured organisms were anaerobes, but in the vast majority of cases, nothing was cultured. There was no pathogen identified, so they really only made up about 0.5%. And aerobic gram-negative rods were by far the most common species cultured. Now, during this time, we're starting to get more evidence for the association of C. diff with anaerobic coverage. And this guideline was really based mostly on microbiological data, not a lot of clinical outcome-based data. So come to 2004, a nice shiny new study came out in CHEST, retrospective propensity-matched cohort study. About 4,000 patients with pneumonia related to aspiration hospitalized in Canada. So they compared what they called limited versus extended anaerobic coverage, and their outcomes were hospital mortality, 30-day readmission, and C. diff infection. So this shows you what limited versus extended anaerobic coverage looks like. That's ceftriaxone, cefotaxime, and levofloxacin versus amoxiclav, moxifloxacin, or one of the limited antibiotics plus clindamycin or metronidazole. So this study showed that there was no significant difference in hospital mortality or ICU transfers. But what they did notice was that there was a small but statistically significant increase with C. diff infection in the patients treated for anaerobes. So some take-home points. Anaerobic coverage, we know now, is probably not needed for most patients who have aspiration pneumonia, and it may increase their risk for C. diff. Anaerobes are way less common than we once thought with modern sampling techniques. But we still need prospective clinical trials to really definitively answer this question, as randomized clinical trials are just very, very limited in this area. Thank you.
Great job, Glenn. Thank you so much. Chat's open for questions. Judges, if you would like to go back through your score sheets before hitting submit, please do that. We are running a little ahead of schedule, so if you need a little time to just parse through your judging sheets before you hit submit on the whole thing, that's fine. But in the meantime, any questions for Glenn?
Some great jobs. In the meantime, Glenn, you can tell me more about your ultimate Frisbee career.
Oh yeah, it was it was brief and not all that distinguished, but we had a club team, and a bunch of the different high schools around town had teams, and there was sort of a local league, so kind of a local rec league type of thing. It was a lot of fun, a lot of scrapes, a lot of skin lost on the field.
Yeah. What was your team name?
Oh God, I mean, I think we were just the Bulldogs because that was our high school mascot. Yeah, not very imaginative. Sorry.
We were the Red Hots, like the candy.
Yeah, that's way better.
You didn't need to tell me it was the candy.
Still waiting for some questions to come in.
Any other thoughts, Meredith? You were in golf in high school?
We're going on this already.
We're gonna, we're just trying to kill some time. If you'd like to come on the ride with us while we get the scores.
Oh wait, hang on. Okay, great
There we go.
question.
Thank God. Shit.
Should we bring back transtracheal aspirates?
Yeah, definitely. Luckily nowadays we have flexible bronchoscopy, which has pretty much entirely supplanted the need for transtracheal transcutaneous aspiration.
And then
So yeah, abscesses. So the current guidelines from ATS say they basically exclude abscess from their recommendation to omit anaerobic coverage. I couldn't find any actual evidence that anaerobes are more likely to be associated with, or definitively more likely to be associated with anaerobes. So I don't think that there's evidence to say that you should, or that there's a good reason that you should. Now with empyema, the management, of course, is totally different. I mean, we're talking about chest tubes and things like that, so that makes sense. But even though the guidelines currently say exclude abscesses, I don't think that there's actually evidence to really support that right now.
awesome. I think that's the last question, right? You
Yeah.
just scrolled.
I think so.
And yes, definitely inertia, Alfred.
Cool. That's probably been like the 2 minutes.
Yeah, well, but we're in
just
the
now.
tabulation phase, and so let me bring up our the break screen that I worked so hard on. Gotcha. So, Meredith, I guess we haven't talked we talked about your golf.
Yeah.
Okay. Anyone have any like crazy clubs they were in? Put it in the chat. Anything that was like, I don't know, just wow.
So yeah, and while you're thinking about this backstory, we played this game at SHM throughout the week as we ran into people to ask them what clubs they were in high school. It turned out it was a really great icebreaker. Spawned a lot of extra questions, and can't help but notice it seems like no one's commenting in the chat really. Wait, here
we got some good stuff.
Great. Show choir. I love it.
Before Glee made it.
Oh, mock trial.
Oh man, now it's blowing up. Now you guys have
Model UN. What a good one.
And Michelle, what was this that you were in? Hold on. I see that you were called. Oh, you were in the show choir and you were called Entourage. Love it.
Marianne
KG was mock trial, gospel choir, soccer. She was a cool kid.
Yeah.
She was cool. No.
Intramural water polo.
Marianne, of course you were in intramural water. Why am I not? Mu Alpha Theta. Oh man. What a wow.
Actually, Mathlete was a recurring theme over at SHM. So
yeah. Supervises D&D. D&D is like stealth, also like the precursor to a lot of improvisers' careers. What I've learned.
What is D&D?
This isn't even boomer. This is just like what is your deal?
I just don't know
Dungeons and Dragons.
Oh.
You know what that is?
Yeah.
Okay. Just making sure. Yes, Monica. All right. We are ready to announce, but before we do, I want to stall a little bit longer. I just want to say thank you to all of our judges. If they have any brief comments before we get to our winner, I would appreciate that. And before I do that, before I open it up to them, just want to thank everybody for being here today. We had close to 70 people on the call, and that's not counting if people were watching together. Great turnout. To Monica, who worked so hard to make sure that we all have our invites and the links and all the things. To Dan Hunt, who was always so supportive with all of my crazy ideas. To Meredith for always just picking up a microphone and just bantering with me. I appreciate it. And to all the speakers, clearly you guys worked so hard to make sure we all got good content today. So appreciative of that. And so without further ado, I would love for the judges, just very briefly, we'll start with Alfred. If you have any brief thoughts, and then we'll get to the winner here in a second.
Yeah, I think that these were a series of amazing talks. whoever wins, it was not easy, and it was very close, very close, very close, and probably on the slimmest of margins. You're all amazing at this. I was very interested in the topics chosen. I thought it showed a wide variety. I just really enjoyed being here. I thought that you all should just keep doing these and submit them to SHM or other organizations for larger talks, because I think that they're the sort of challenging the status quo type of talks that are needed out there. So thank you all very much.
And again, thank you so much for being here. Lauren, what you got?
I echo everything that Alfred said. Thank you so much for inviting me to be part of this. I learned so much from everybody's talk, and I just love all of the evidence incorporated into these talks. It's really, you all made such wonderful points about how we should practice medicine and really backed it up with evidence. So I know I'm going to be able to be confident in my decision-making in some of these gray areas. And so very grateful for all of you.
Thank you, Lauren. And then Nilu, our inaugural winner and now judge, what you got for us?
I just really appreciate having this venue to hear from people across the country with so many interesting topics and getting to learn about all of them. And I also really especially appreciated the topics that had the QR codes at the end of it. I'm going to take this away as like something that I will do in the future of just giving people things that I'm so excited to learn about. I was trying to like quickly screenshot things, but then you gave me your slides at the end, and I am very appreciative of that too. I'll also echo that I think this is probably going to be a really close tie for a lot of them, because everyone did an incredible job with the talk.
Great. Thank you guys so much. And just to make sure everyone, our speakers see what Dan wrote in the chat. These are national invited presentations for your CVs. So make sure that's where you put them for your CVs, for those of you that care about that. And all of you probably do. So, all right, Monica, I think we have a winner. Will you please do us the honor of putting it on the screen? Oh my God, so much suspense.
Dun, dun, dun.
And the winner is Dr. Caroline Coleman out of Emory. Congratulations, Caroline. What a ride it's been.
Thanks to everyone who helped me get to this place. So I appreciate it.
Awesome. All right, guys. Well, we are done ahead of schedule, and I'm so excited. That makes me so happy. Congratulations again to Caroline and all of our speakers. You all did such a great job. We will have a couple things come your way here in the next week or two. We'll have access to the video. So for those of you trying to snap QR codes, you'll be able to do that. And then because it's me, there'll be a playlist including all the songs that our judges and speakers picked, and then me and Meredith too.
Yep.
So if I don't think anyone else has anything, I don't, and I'm in charge of it. So everyone have a good night, and hope to see a lot of you next year and at SHM and all the things.